Okay, so this is the we're starting the white blood cell series, as I talked to you about before, and this lecture is about the white blood cell abnormalities, but the non-malignant ones. So this is about non-neoplastic disorders, right? When we talk about white cell abnormalities, for the most part, we're referring to cancers of white blood cells, so blood disorders, right? or that pertain to white blood cells. Okay, so this lecture was originally created by Dr. Elaine Cohen in the Rutgers Medical Lab Science program. She is a retired doctor now. So basically, when she gave me hematology, she gave me all of her already prepared lectures, and then so through the years, I just updated the lectures, and then I was able to use them for Valley as well. So we know the concept. We know what neutrophilia is, neutropenia is. So that's really how what we used to introduce this chapter. Neutrophilia is an increase in the neutrophils, anything over 7 and 8 times 10 to the 9th. And it happens because of either pathologic causes or benign causes, right? So things like stress, fever, a lot of exercise, cortisone therapy, that can lead to some neutrophilia in a patient. Some pathologic causes, as we know, are acute bacterial infections. And this is where you would see neutrophilia plus a shift to the left. You would see toxic granulation, toxic vacuolization, and also dull bodies, right? There's another type of pathologic cause that's very that it pretty much resembles an acute bacterial infection in a shift to the left, and it's called a leukemoid reaction. And this is when the white blood cell count goes over 50,000, but it's not because of leukemia. It is really what it is an exaggerated response to infection. Another way that you would see neutrophilia are in inflammation states, toxic states, destruction of the tissue, acute hemorrhage, hemolysis, and also malignancies, right? So things like myeloproliferative disorders and other conditions will lead to an increase in the neutrophil count. 1 second, let me just text Marietta and tell her, because she was worried that I couldn't start the lecture. Okay, so that's neutrophilia. The opposite of that is neutropenia, right? So this is, a slide in which you would see a patient with lots of neutrophils. So neutrophils, segmented neutrophils, pretty much the same thing. Neutropenia is a count that's less than 1.8, and the severity is very important here. So this is when we take into consideration the ANC, the acute, absolute neutrophil count. And neutropenia, because of the decrease in neutrophils and in what the neutrophils do, it could be dangerous if it gets really, really, really low. So there's mild, moderate, and severe neutropenia. Severe neutropenia could be very, very dangerous. So those are the counts. And we, in hematologic disorders, it could go either way. It can go where your patient has very high white blood cell counts, and then you can go where it's very, very low, where it's like almost non-existent. Okay, but that could be very dangerous because there is no immune response. There's no system to fight the infection, and it can overwhelm the body. So some causes of neutropenia: decreased production due to B12 or folate deficiency, bone marrow failure, certain drugs or malignancies that affect the bone marrow. And it could also be due to the destruction of neutrophils, which is an overwhelming infection, immunologic, right? So some antibodies or autoantibodies or autoantibodies that are attacking the white blood cells, or hemodialysis. So with neutrophilia and a shift to the left, you would see other characteristics in the cells than just looking at the increased number, right? So you would see things like toxic granulation, toxic vacuolization, or dough bodies. Toxic granulation are these very large granules that you see in the cytoplasm, and that's usually a response to an infection, or sometimes it's after therapy. And a toxic vacuolization case can go along with toxic gran, and you see lots of large vacuoles, and that's typically due to the phagocytosis of bacteria and fungi. But you can also see it in old samples, like old dying samples. And then you have dough bodies, which are these little structures. They're small, tiny blue granules of ribosomal RNA, and they're typically found in infections, pregnancies, inflammation states, also after granulocyte monocyte colony stimulating factor therapy. Some acquired abnormal morphology that you may also see is a hypersegmented neutrophil, and that's typically seen in cases of vitamin B12 or folate deficiencies. It's found in megaloblastic anemias. Megaloblastic anemias are due to either B12 or folate deficiencies. Sometimes you see a necrobiotic neutrophil with which is a neutrophil that has a degenerated nucleus, and it has large numbers of granules. Eosinophilia is an increase in the EO count. That's typically due to allergic reactions and parasitic infections, some immune disorders, and also in chronic myelogenous leukemia. That was the CML slide that we saw the other day together. You saw lots of EOs, right? Lots of EOs and basophils. And basophilia is an increase of basophils, and you would see that same thing in CML or in hypothyroid states, or ulcerative colitis. Monocytosis is when the count is over 0.8, and you can see that in tuberculosis or subacute bacterial endocarditis, syphilis, parasitic or rickettsial infections, also in the recovery phase of acute infections, and in certain leukemias. You also have lymphocytosis, which is an increase in the absolute lymphocyte count. The lymph count for children varies a little bit from the one in adults, so it's something to keep in mind. Some of the causes of lymphocytosis, especially if you see it in mature lymphocytes, it could be some bacterial infections like Bordetella pertussis or viral infections. The presence of reactive lymphocytes kind of gears you towards thinking that there's some sort of viral infection happening, right? So there are viruses like the EBV virus, Epstein-Barr virus, cytomegalovirus. There's HIV and other viruses that lead to an increase of reactive lymphocytes. Lymphopenia is the other way around. You can also have lymphopenia from immunodeficiency diseases like systemic lupus, tuberculosis. There is tuberculosis, not immunodeficiency, but tuberculosis can lead to lymphopenia, drugs, and also radiation. So here's some examples of your reactive lymphocytes. We talked about these a little bit. These are antigen-stimulated lymphocytes. Some of the other names that you'll see are variant lymphocytes, atypical, activated lymphocyte, virocyte, right? Transformed lymphocyte. But the ones that you'll hear the most are reactive or atypical, okay? But we use reactive lymphocytes for the most part. So these are cells that are large, and they come in many different forms. They do look like blasts, they look like monos, and they look like plasma cells. So that's what makes it so difficult to differentiate them visually, right? When you're looking at the microscope or when you're looking at a screen. They do have stretched nucleus, blue cytoplasm. They display that radiobasophilia, and they have heterogeneous morphology. So it's different. One will look a little bit different than the other one. You know, you don't find them to be exactly the same. And reactive lymphocytes can be found in infectious mononucleosis and other conditions as well. So all the other viral conditions would lead to an increase in reactive lymphocytes. So HIV, toxoplasmosis, hepatitis A, B. They can also be found in very low numbers in healthy individuals. So again, they're large cells. We talked about these the other day. Obviously, somebody was undercalling them, right? But you have an idea of what they look like. They have decreased NC ratio and a lot more cytoplasm. So by heterogeneous morphology, you want to think of like, well, there's not one that's going to look exactly the same as the other one. So the whole nature of it, it's like it's going to vary. Okay, they vary a little bit. So they have each cell, even though they're reactive lymphocytes, they have a little different differences between them. Okay, but they shouldn't vary that much in terms of their morphology. But when you remember the characteristics, like they're usually large, there's more cytoplasm than there is nucleus. And there's some radiobasophilia. They look like they're pushing the cells away. They look like they're reacting, basically. So we must keep that in mind. Infectious mono is a common condition that we get to know in the lab, especially in hematology, also in micro, but I think you've seen a little bit of it in coag. It's caused by Epstein-Barr virus and affects adolescents and children as well. And some of the symptoms are fatigue, fever, sore throat. There's the enlargement of the lymph nodes and also splenomegaly. But Epstein-Barr, infectious mono can get complicated if it's untreated, and it can lead to abnormal liver function tests. It can lead to autoimmune hemolytic anemia because of the anti-little I, thrombocytopenia, and some other secondary infections as well. So what you get to see is that the white count, it's increased. It goes from 11,000 to 20,000, and there is lymphocytosis with reactive lymphocytes. Another way of detecting it is by looking at the heterophile antibody test, which will give you a positive, and also a positive for EBV antibodies. With the heterophile antibody, that's produced in response to the actual virus, which is EBV virus, right? So these cross-react with the sheep and horse red cells on the reagent that you employ for this particular test. So there's something typical of these heterophile antibodies, something that we need to understand. These antibodies, these heterophile antibodies, they're antibodies to the EBV virus, and they cross-react with the antigens that are on the sheep and the horse red blood cells, right? We have to note that these reactions could be negative, right? This antibodies can be negative in 25% of the patients in the first week of infection, in 5 to 10% of patients in the second week. So it becomes less during the second week. But they're usually positive in about just 25 to 50% of children that are under 12 years old. So it makes it very difficult because of those windows to accurately diagnose infectious mono, but you can diagnose it. It's just that we have to be very mindful of the windows in which, what are the possibilities of the reactions with the antibodies. Some other conditions too are very important. These are not neoplastic conditions, so they're not cancers, but they are conditions that look like cancer, right? They are anomalies that occur, and they, in some way or another, they inhibit the patient. They cause something, and so they're important for us to know. Pilger-Hewitt anomaly, PHA. It's a genetic disorder. It's an autosomal dominant mutation in the laminin B receptor, and it causes hyposegmentations in about 80% of the cells. So Usually the neutrophils, when you look at them, they have 2 or 3 segments, right? And they're connected by that filament. In Pulgar-Hewitt, you don't really see that. You see like 2 lobes that are connected by a filament. Sometimes it's just one continuous lobe. The only difference here is that the chromatin structure of the Pulgar-Hewitt cells is very, very, very coarse and clumped. Okay, so it's very dark. And I just don't know who I just admitted. So hi. Okay. So this comes in different forms. The heterozygous form, which is the known as the bikini top shape of the neutrophil. There is the dumbbell shape. Oh, it's okay. Don't worry, Liz. The dumbbell shaped, it's also called the pince nez shaped, which are the benign forms. There's the homozygous form in which the nucleus looks a little bit more round, and that's associated with skeletal heart and cognitive abnormalities. So there's also something called pseudo Pulgar-Hewitt, and that occurs in malignant myeloproliferative neoplasms. Another condition is called the Alder-Riley anomaly. This is a rare mutation. It's autosomal recessive. And when patients get this, there's an accumulation of the mucopolysaccharides in the cells, and you start to see these purple granules, there's dark purple granules in the neutrophils, but you have to keep in mind that you may also see that in all the other white blood cells. But these purple granules in the neutrophils seem a little coarse and a little darker in color. May-Hegling is another condition. May-Hegling anomaly. It's an autosomal dominant condition. It's rare. In here, there are mutations in the MYH9 gene for the non-muscle myosin heavy chain type 2A. And what you see are these large dough body-like inclusions in the cells. So they're kind of bluish in color. But this predisposes the patient to a higher risk of infections. And you'll also see that there's thrombocytopenia, giant platelets here, as you can see here in this picture, and some functional defects of the giant platelets, which can lead to bleeding. And then there's the Chediak-Higachi syndrome. This is another condition that is very rare to see, but it affects the white blood cells. It's an autosomal recessive condition. You see abnormal lysosome granules in the cells, so these really, really large, big granules. It causes neutropenia, which predisposes the patient to a higher risk of infection. Thrombocytopenia because of abnormal platelet function, which can lead to bleeding. And then also it leads to the loss of pigment in the skin and the hair, which is albinism. And there is chronic granulomatous disease. This is an autosomal recessive X or X-linked condition. There is a phagocytic defect in here, in which the neutrophil is unable to kill some of the phagocytized bacteria or the fungi. This is susceptible to staphylococcus, enteric organisms, yeast, and the patient is prone to getting chronic pyogenic infections, which can lead to an early death or a death in their childhood. And then next you have Gaucher's disease. This is an autosomal recessive condition. There's a deficiency of the beta glucocerebrosidase enzyme, and there is an accumulation of the glucocerebrosidase enzyme in not the side in the macrophage, in the macrophages, in the bone marrow, also in the spleen or in the liver. And You can also see the deficiency or the accumulation in osteoclasts, which are bone stimulating cells. And what it is just like a large cell, okay, as you can see in the picture here. It's a very large cell. It has eccentric nucleus. And the cytoplasm kind of resembles the skin of an onion. Okay, but then the eccentric nucleus is, it's kind of like a very nice brown nucleus that gets pushed to the side. And then the next condition is Niemann-Pick disease. This is an autosomal recessive condition. This is where it occurs because of a deficiency in the sphingomyelinase enzyme, and then there is an accumulation of sphingomyelin in the bone marrow, the spleen, the liver, and the lungs as well. And the cell becomes very big. There is an eccentric nucleus, but it has like a foamy type of cytoplasm, and they have usually these droplets, these drops of lipids in them. But the whole term that is used to describe Niemann-Pick is a foamy looking, type of cytoplasm. So these are pretty much just like a summary of the non-cancers, non-malignant deficiencies that you would see in white blood cells. Any questions? Okay, let me stop this recording.